tonight we're going to talk about some of our current research, some of the work we're just starting to get going, and perhaps some future research, and also best practices for ADHD for pharmacological treatment as well as behavioral treatment. So there's 8 of us, so some of us, like me, might be talking really quickly to get us through this evening. Here are my financial disclosures. We receive money from the National Institutes of Mental Health for much of our research, Department of Defense for a Fragile X study, the Administration on Developmental Disabilities. From Shire Pharmaceuticals, we're about to start a study looking at the effects of medication on self-control and academic functioning, and Atsuka for a study at looking at Tourette's. So tonight, I'm going to spend most of my time talking about our MINT study, which is Mapping Impulsivity's Neurodevelopmental Trajectory. And this is the study that Dr. Adhd was talking about, funded by the National Institutes of Mental Health. It's a longitudinal study. That means we bring people in and we bring them back again a few more times to look at changes in brain development and brain functioning over time. We're looking at risk-taking and self-control. How many people out here tonight did any of the games out there? Raise your hand if you did. Okay, was there any risk-taking involved? Thinking maybe about Jenga, whether to go forward or not, or any of the games? Okay. So these are sorts of instances in real life where you're faced with decision making. And our decisions affect our outcome, and we're looking at how that changes in development. So who has ever heard of the marshmallow study by Walter Mischel? Raise your hand for that one. That's a pretty well-known study done in the 70s where they put fluffy, delicious marshmallows in front of 4-year-old children and said the longer you wait, the more marshmallows you get. It was one trial. And that study was highly predictive of a number of things, looking at educational outcomes, SAT scores, occupational success, physical health like body mass index, self-esteem, and substance abuse. Well, we're hoping to extend that by looking over time what happens in the adolescent brain. So for me, for self-control oftentimes involves chocolate. Because if anybody knows me, I'm highly gravitated toward anything chocolate. I like fruit, don't get me wrong. And I know fruit is better for me in the long run. But if I see chocolate, oftentimes I'll say, okay, I'll have the chocolate, but the fruit will be good too. And so it turns out you can actually look at different systems in the brain. And my colleague Sam McClure did this in 2004. And he looked at what systems were more activated for highly rewarding sorts of activities or choices where you gravitated toward. For him, it was really simply just a small sip of juice immediately or more juice later. And what he found are these areas of the brain, the nucleus accumbens here and the orbital frontal cortex were more activated when thinking about reward. When thinking about the effect of whether you would eat the chocolate cake and the calories versus having the fruit and maybe delaying and thinking about the health outcomes of that, these parts of the brain, the prefrontal cortex and the parietal lobe, get activated. And that's when you're doing deliberative choices. So when your child is thinking, should I text my friend right now? Or should I go back to my homework because my homework, I'll get better grades. If I get better grades, I'm more likely to get into college. I'll make a better income. So really thinking delayed, that's where these choices come in. This is where these parts of the brain are actively involved in choices. So Dr. McClure did this research in 2004, and these were healthy undergraduates primarily, one session. And so what we're hoping to do is look at what happens in ADHD and what happens over time if you repeatedly study individuals. Now, the other thing that we've really learned just in the past few years is that your age makes a big difference how you respond to these choices. Any parent of a young adolescent or young adult will know that that's true, right? So we get more concerned when they have keys to the car and access to other things that we start getting more concerned about. And if you look at this graph, you look at age here, this is increasing age. So this is, let's say, birth, and this is maybe up to mid-20s or so. And this is brain regional activity. What we find is that initially, even though these children may seem impulsive when they're young, actually during young adolescence they become more impulsive and they gravitate more toward rewards. Now, it was great that we discovered this, but I have to say the insurance adjusters knew this years ago, right? That's why the rates are so much higher for adolescents. Then what happens we think about late teens or so, you gravitate less towards reward. So this part of the brain is actually better controlled. In ADHD, we don't really know, but based on our pilot data, we think that they're actually more activated for rewards and gravitate even more toward them, hence why we worry about their self-control issues. Now, the other part of the brain that was thinking, oh, that fruit would be much better for me, that's the control part of the brain, prefrontal cortex and so forth. That grows in a more linear fashion, but it's slower than the development of the area for the reward. And so in ADHD, what we think is probably even slower yet than typically developing people. Typically developing people, we think about mid-20s is when that part of the brain kicks in and works together, so together this system can really determine which are the best choices and long-term outcomes. But for ADHD, we're thinking maybe late 20s, early 30s, but again, we don't know yet, and that's what we're hoping to try to figure out. The other thing that hasn't been done with most of the brain imaging studies is really looking at the outcomes and how it relates to real-world functioning. And most parents that we talk to, they have a lot of concerns about academic functioning because that seems to come up on a very regular basis, and we know that predicts long-term health and outcome in a lot of ways. So we're going to be tracking that. So as the children will come in, we'll be looking at their brain functioning, how they do on risk-taking tasks and so forth. But then we'll be collecting a lot of other measures, such as grade point average, looking at whether or not they graduate from high school, do they go on to a trade school or to college, how do they do on standardized achievement testing, what is their attendance like in school, and also we're hoping to look at occupational success, early occupational success because they'll be young, looking at attendance on the job as well. Do they drop classes? And as I said, early occupational success as well. So what are we going to do with all this information? So one, I think it's great to learn about the brain and how it develops and how I think different people might have different trajectories, and I think that's going to inform us better about what we need to do in terms of developing treatments for ADHD, because I think some people get a bigger hit in the reward system, some may be in that cognitive control system, some may be a little bit of both. But if we have a better idea of how these trajectories emerge, we can develop better treatments. And to be honest, there have been very few treatments in the adolescent age that seem to be targeted to this. But now that we know brain development still occurs in adolescence and young adulthood, I feel like we have another opportunity for treatment that we didn't recognize before that we had. And what we're looking at here in the long run was we've looked at cognitive training a little, and we've had some good success, and Mr. Rutledge will talk about that, but we don't know for sure how that relates to impulsivity and ADHD yet. We're looking at maybe you can build resistance to distractors, and self-control, can you build self-control in older children as well? So that's what we hope to do in the future, and we have flyers out there about our studies, so we are recruiting. And I just also want to say, besides the wonderful people you'll see on the panel tonight who are collaborating with me on this work, I also want to acknowledge my collaborators at Stanford University, Sam McClure and Walter van de Bos. And thank you for your time.
So what I'm going to talk a little bit about is what students need to be successful, what some of the common barriers are, what we mean when we talk about multimodal interventions, and then how we begin to identify support system partners that would be helpful for teens. So academic success requires sufficient intellectual and cognitive capacity, the ability to organize information and time, the ability to work independently, motivation to work towards long-term goals, and knowing how to effectively use resources and support. Some of the barriers to this we know are conditions like ADHD, conditions like learning differences or learning disabilities, perhaps social or emotional issues, or perhaps cultural issues in terms of how a particular family views education and educational attainment. So when we talk about multimodal interventions, just a brief list of some of the things that we're thinking about are how do we improve learning strategies for kids and teens? Assistance with time management and planning. How do we get appropriate classroom accommodations? And what might be necessary testing accommodations? And just briefly to think about what a few of the learning strategies and time management strategies are, For learning strategies, it could be something like multi-sensory processing. That is meaning using different ways to acquire the same sorts of information. So not just reading, but perhaps writing, perhaps drawing, perhaps speaking into a recorder and using that to listen to the information later on. Being able to do more active and purposeful reading. Having lots of repetition. One of the things that we know for kids both with ADHD or with any sort of learning challenges is that having repeated exposure to the same material helps you to learn it better. And then there's specific things like using mnemonic devices. For those of you who are old enough to remember when you had to learn all the colors in the rainbow and you had to use Roy G. Biv, which was a way to help you to understand like, oh, there's red, there's green, there's all the various colors in the rainbow. And an additional thing could be study aids, learning how you highlight effectively, learning how to use a red pen. I mean, just very sort of simple tools that could be helpful in terms of learning strategies. And in terms of time management, it's knowing how to schedule study time blocks and how to take effective breaks, how to prioritize what the workload is. That's what needs to be done immediately, what could wait till later. How we help teens to postpone unnecessary activities or something that could be done later on. And we have all kinds of now electronic devices out there to help us. And so it's helping kids and teens to effectively use those smartphones, those iPads, those electronic planners, because those can all be tools that are helpful in terms of academic success. And so this is just an example of sort of a sample strategy exercise. So say a teen has a goal of, writing down something that they want to accomplish and what could be some of the possible obstacles to achievement. So the goal might be, I want to get better grades. The obstacle might be, I never feel like doing homework. Does that sound familiar? So strategies could be, helping a teen to know, okay, let's ask a teacher for study tips and facilitating that happening. If your school happens to have a homework line, sometimes some of them have hotlines that you can call, some of them have support lines that you can go online for. And helping students and teens understand something like cutting out maybe an hour of watching videos online so that you can have more time for homework and to be able to do it at your own pace. And we all know, from some of the things that Dr. Schweitzer said, this is tough for teens to do. So a very important piece is how do we identify the support systems? Who are going to be the partners who could help with this? So in terms of thinking about school-related resources, it's what can classroom teachers do? What about resource teachers or learning center teachers? What can we get from school counselors? How might a tutor be able to help? And how might a peer study group be able to help? And then also to think about personal resources, parents, friends perhaps, therapists or counselors, or even something that newly we've been talking about are ADHD coaches, people who specifically work with teens and young adults to help facilitate how they can begin to accomplish all of the things that they need to do in school. And then lastly, just to think a little bit about, might there be a need for any sort of mental health service and helping teens get the appropriate services and referrals for psychological treatment, particularly when we're thinking about things like anxiety or depression.
So I was in San Francisco last week and I met with a dear friend, a pediatrician from New York, a much more experienced individual. And we were talking about our shared experiences. And he told me that, he loved these meetings, he really enjoyed, he learned a lot, but he gets so many questions from families that he was looking for some of these more specific type of questions that he said he was having difficulty explaining to families or answering them, to be truthful. And some of these areas we have limited information. So as you see, this was inspired by a Woody Allen movie. And my interaction with parents and families, sometimes they are just as nervous asking questions about ADHD. So we'll try to answer, based on my experience, we'll try to answer some of these issues that I get all the time from parents, and I feel they are very important for us to discuss. So Hippocrates talked about ADHD at around 400 BC. And he said people with inability to shift their focus or inability to focus because their soul moved too quickly. He described it very elegantly, and it's pretty much same our observation, except we have much more information, tremendous understanding of biological underpinnings because of studies that Dr. Schweitzer talked about. But this is not a new diagnosis. We just know much more about the disorder or about ADHD. Adults with ADHD, we have very limited information in comparison, and we are learning more every day. One point I also want to make, the impact of ADHD is probably bigger today because of the increased need, increased academic importance in our lives, and increased demand for executive function. Do we really need to have our child with ADHD treated for his or her condition? Social immaturity appears to be a significant problem in children, teenagers, and adults with ADHD. And with the treatment and services, it's amazing. I saw a child earlier. I've been working with them for about 3 years. And his mother told me, you know, Dr. Pakurek, my child looks so just like his peers. When I watch him on the playground, he looks very typical. He doesn't really look, he's not impulsive anymore, and he's able to relate to other kids so much better. You will see that incredible improvement with these individuals, but I feel, and the research supports this, the services, which we will discuss a little later, timely applied services seem to be very important. I also want to talk about chronic demoralizing effect of ADHD in individuals, both teens and adults. They deal with this day in and day out. They have certain potential. They feel that they are functioning significantly lower than this potential, that they know they can get there, but they are not always certain how to do that. So there is that chronic demoralizing effect if they are not supported by the parents, educators, and treating physicians. What is the successful basic treatment approach for ADHD? Very simple, multimodal, everything that you see on that, but it's also very complex, right? And certainly involved in systems. But one system probably is the most important system on that slide, and that is the family unit. And every day I observe this. The more involved the families are, the better the outcome. If I'm working with one parent, the other parent is very resistant to diagnosis or the treatment, or they are just not working together, I know the outcome is going to be much more limited in a year or two in comparison to another set of parents. That's why we have wonderful parent support group that Dr. Dixon runs very efficiently, and it really makes a big difference. There is some research now that tells us family involvement means positive treatment outcome. So our clinical observations are now being supported. Do children with ADHD have certain strengths? I get this question a lot from parents too. Absolutely. They are fantastic visually. Think about their video game skills. They are better than any other group, right? They really can conceptualize visually very well. They are very creative. They can see the big picture, and they can be very positive in terms of motivating and supporting others. But this happens when they are supported by the parents, educators, and treating physicians. So we need to focus on their strengths and the positive attributes. We cannot just focus on the critical part, the parts that we want to help them improve. The other part is, I think, just as important. Does treating ADHD correct learning disorders? I got this question this morning. No. The answer is no. But learning disorders are so common in ADHD, children with attention deficit hyperactivity disorder, and of course adults. If you treat ADHD, you will help minimize the negative impact of learning difficulties. They will process better, their working memory will function better, and then you will bring the school services to address that. The result will be much more successful than if you ignore the ADHD and leave it out of the equation. Is there an agreement among experts regarding treatment holidays or drug holidays in ADHD? I know you get this question. I'm being asked every day. No, absolutely. We can't seem to agree on many things. This is no exception, but a couple of points. Weekends and summers are when the school is no longer in equation, and parent monitoring is much less too. So you are already removing the structure from the children's lives and teenagers' lives. So they have less monitoring, they have less supervision, they have less structure. In addition to that, if you also remove the frontal cortex support, i.e. the medication treatment on the weekends or in summer months, what does that spell? That spells trouble. They will run into road, they will get hit by cars, they will get pregnant, they will start experimenting with drugs on the weekends during the summer months when all those support, including medication treatment, is removed. So my suggestion is do not do that. Keep the child on the medication. This is very important. I just want to talk about the pharmacogenomics because this is very exciting, and we are already doing this in major depressive disorder. You get a DNA sample, a swab. You send it to the lab, and you have a genetic makeup of the individual, of the patient or the family, and it will tell you what medication side effects can be expected in that particular genetic makeup, which medication is most likely to help, and high or low risk for a group of side effects, potential side effects. This is being done in major depressive disorder in certain centers, and I don't see why we cannot improve on this, both in our clinic and in general. I just received an initial data that they already, I believe at Mayo Clinic and Cincinnati, somewhere in Cincinnati, they just started doing this for ADHD as well. So I'm very hopeful that we will be able to bring this to our program very soon. My email address is at the bottom. Feel free to shoot an email. Thank you.
I think all the people who've talked before me have made it a lot easier for me to talk about managing ADHD, and they've already touched upon some of the ways in which we address and the multimodal application of treatment. Okay, so this is just a very brief kind of picture to kind of talk about what ADHD is, and not just kind of the messy room, but also the quietly distracted kid. So further, I think everybody has talked about this, and I'm not going to spend a lot of time, but I really want to emphasize that when you think about treating ADHD, it really is multimodal, and you really want to think about it as a recipe, and you need a lot of different things for it to kind of taste right. And any one ingredient missing can make it or break it, and you really need to think about everything together helping the child. And also when you think about ADHD, the approaches a lot of parents ask, well, do we need to treat it? Can we just not, make accommodations in school and, help them through decreased load or other things? And, I often will tell them, when you think about treating it, you can think about either learning how to live with it or figuring out a way that it stops getting in your way so that you could live to your best potential. And, I honestly believe that none of the treatments that we have are perfect and completely address every single aspect of ADHD management, and I feel that's why you often need a little bit of both, where you want to bring the person closer to the world and the world closer to the person, so that you can kind of meet somewhere in the middle with both, learning how to manage the symptoms as well as reducing the symptoms, so that we could get a good balance between the two. And often one part of the recipe that I think I'm going to talk about a little bit is medication management for reducing or treating symptoms of ADHD. If you just look at the evidence and studies in terms of, do we need medications to treat ADHD, or how much does it help? And when studies have looked at reducing symptoms versus symptom management, we have found that medications is an essential part of treating ADHD. And I don't think it's the whole answer, but it is an important answer in terms of treating ADHD. So, just very briefly, the medication groups that we can very broadly think about when you're thinking about treating ADHD are stimulant medications and non-stimulant medications. And then I have, names of all the medications that are up there, both mixed amphetamine salts like Adderall, and the newer one, Vyvanse, methylphenidate products like Daytrana or Metadate, Focalin, Concerta, Ritalin. These are all names that you might have heard. They're non-stimulant options for kids who might either not tolerate stimulant medications, or there might be other reasons not to consider stimulant medications. And atomoxetine or Strattera is one of them. Clonidine, or also Catapress is what it's also called. And the longer acting version of this, which has come out now, where instead of having to dose it multiple times a day, you can use once a day dosing, and it's called Capway. And also another medication, guanfacine or Tenex, and they also came out with a longer acting version of the same medication that's Intuniv. So often parents will come in and ask, well, how many do we have to try? And are we going to find the right medication right away? And my answer often is, well, we don't have so far kind of the genomics to tell us, well, use this one, and this is the exact one that's going to work for this kid. So till we can get that and start working in that fashion, sometimes we try the first couple ones and it works right away. And sometimes parents are going to feel like I'm a mad scientist just throwing medications at the kid and seeing what will stick. But it really is sometimes kind of living through it to find what works best for the kid, till we can have a better way to really kind of streamline and help us figure out what is going to be a good medication for a child or adult. Common issues, I'm just going over the really most frequent problems that we see with medications: the appetite suppression, sleep onset difficulties that some kids can have, especially the longer acting medications. Again, something that can be addressed with either changing the duration of action or in other ways, depending on how severe the sleep disruption is. Irritability, again, depending on the different profiles of the medication. Some kids and parents ask if it's going to cause irritability, but often we see it most when the medication's wearing off. And this is where they're also coming home from school, and the parents feel like the medication's not working at all, but you get a different story from the teachers versus the parents, and often a lot of that can be related to just the medication wearing off, amongst other factors. And then there's a question of tics, of, can these medications cause tics? And we certainly see that there's a, genetic sharing of risk. So we see that family members of kids with ADHD have higher risk for tics, and the kids who have ADHD have a kind of underlying genetic risk. And the medication can uncover it and unmask it. And so you can see that, but for the most part, it's not something that's going to cause a kid to have a tic. What are some of the myths? Is that, the first one is not a myth. It does cause appetite suppression. But the second one about that appetite suppression in the long run is going to cause differences in the growth potential of a child. And there are some studies that have looked at it and looked at kids who've been on medications and without medications. And they found, kind of just in a very, watered down assessment, but that the eventual difference was a difference in height of, I want to say, a couple centimeters, but not a big, huge risk based on projected height and weight, based on parents' height and weight and their growth curves before they started the medication. that they will cause personality changes, and we typically really don't see that. If there is irritability or other reasons which look like the kid has a different personality, it might be a side effect, and sometimes changing the medication can help with that. I think Dr. Pakurek has already addressed the issue of taking breaks from medications, and we really don't recommend that. These are more tests for attention. And the other part is that the stimulants can cause heart problems, and this is also a question I get pretty frequently about, well, I've heard or I read on the internet that it's going to cause my kid, or I'm going to have cardiac problems because of this. And really when you look at all the evidence that looks at it, we really don't see any problems with, unless somebody has a pre-existing cardiac condition where their heartbeats have to be really timed in a very tight range, because any increase is going to cause them to go into arrhythmias or things like that. So if there's a very strong family history of cardiac arrhythmias, or if the kid has had multiple kind of fainting episodes, then we might get an EKG and look at it. But it's not a routine thing. You don't need to routinely get EKGs before starting medications. What's the evidence? And this is something else I get asked a lot, and I'm going to briefly address that. And so I get asked a lot about, diet changes, cutting out sugars or cutting out certain, food groups. Is that going to really help? Supplements, should I give them omega-3s? Should I use other over-the-counter supplements? What about food additives and food colors? And, what should I do? And my usual answer is, if you look at the evidence in a small percentage, it might help a small percentage. But at the end of the day, it's really about balancing risk and benefit. And the risk here is, you're trying to get an impulsive, hyperactive kid to not eat things they like and eat certain things they might not like, and how much of, distress and family conflict that's going to cause. And you really have to balance that with how much benefit you're really going to get from it. And so I don't think there is one right answer, but you just have to kind of weigh the benefit with how much distress it might cause. And then neurofeedback is something that parents ask a lot about. And again, I think, from my understanding, there isn't enough data to say, please go ahead and do that, because I think people are still looking at what the evidence is and how much of an impact it does cause, especially considering that it's a pretty expensive and usually out-of-pocket treatment that right now I don't know if there's enough evidence to say kind of please go ahead and everybody do it.
I'm going to talk to you about a relatively recent research avenue that we've started to explore, and it's also in conjunction with Dr. Ruth Salo at the Imaging Research Centre, and that is ADHD and substance abuse. And I have research support from NIDA and NIMH. So more individuals with ADHD meet the DSM-4 criteria for substance use disorder compared to the population. And then when you look at people who actually go to treatment for substance use disorder, a huge percentage of those people turn out to either have treated or untreated ADHD. And this comorbidity of substance use problems and ADHD, it turns out that there's a lot of evidence that it's very problematic for treatment. So this comorbidity represents a serious problem. So why do we care about this comorbidity? Well, as I just mentioned, people with ADHD and substance use issues, they have different challenges during treatment. For instance, it turns out that they relapse more often. They have more difficulty complying with the treatment itself. So knowledge about what factors are involved in this condition might help us to come up with tailored treatments for these individuals and to help to give them tools to actually recover and stay sober. Also, in looking at a condition like ADHD, which has a high risk for substance abuse, might give us clues for why people with ADHD are at risk for substance abuse, but also identify cognitive markers for risk for substance abuse in general, just in the general population. And I'll go into that in a little bit more detail. So we're looking at a number of different aspects. For instance, Dr. Schweitzer was talking earlier about reward and how that influences your behavior. But in particular, what we're interested in is sort of the control over those urges. So the reward is the urge to do something, and cognitive control is your control over the urge and being able to stop yourself from doing it. And there's a number of different aspects that we can investigate, but I'm going to talk to you tonight about performance monitoring, and specifically how detecting your errors is important. So in order to be able to do something effectively, you need to be able to monitor your own behavior and assess whether you're making errors. If you are making errors, then you need to implement some sort of corrective action to make sure that you don't make those errors in the future. So I like to think of the example of driving. I'm sure many of you usually take a certain route to work or to school, and you're driving in your car and you go into automatic pilot mode. And all of a sudden, you want to go somewhere before you get to work, say the laundromat or something, and all of a sudden you're driving and you realize that you've missed your turn off because you're just in automatic pilot and you're driving along. So something in your brain goes off, you realize you've made an error, and the corrective action is to make a U-turn and go back to your correct turn off. And it turns out that in certain tasks, people tend to slow down after they make an error. So they're going along really quickly, responding, they make an error, then they slow down and are more careful on the next trial. And there's a certain part of the brain that lights up when you make an error, and it's called the anterior cingulate cortex. So it's thought that a signal goes off in your anterior cingulate cortex when you make a mistake, and the signal is passed on to the brain's referee, if you like. And this referee engages attention control and makes sure that you're more careful on the next trial and in future responding to make sure that you don't make another error. So what practical implication does this actually have in addiction? Well, if you think about it, it's an aspect of insight into your behavior. So an addiction is characterized by this inability to recognize dangerous situations, or you keep doing the drug even though you're having all these really negative consequences. So there's some aspect of denial or inability to evaluate your behavior effectively. In addition to that, it turns out from our pilot data that people who make, so I'll just show you here because it break it down a little bit easier. These people up here are people that are slowing down after they make an error, which is the thing that you should do. You're slower and more careful on the next trial. And it turns out that those people don't have a whole lot of relapses in their past. These people down here are people that are actually speeding up after they make an error, which is not being more slow and more careful. And it turns out that those people are the people that in their past have relapsed more. So they've gone into treatment, relapsed, tried to get clean on their own, relapsed. So they've relapsed a number of times. And we have chosen to study methamphetamine addiction because it's a stimulant, so that's obviously got a lot of commonalities in ADHD as stimulants are an effective treatment, but also it's a powerfully addictive drug and it's very neurotoxic, so it hurts your brain to do it. So these are all people with ADHD who have had a history of methamphetamine dependence in their past. All the participants that we work with are clean currently. So we noticed in our group of participants that there was a very specific effect of having ADHD and having used methamphetamine in the past. So if you look at the lines, you can see that on the left in the pre-error, that's their reaction time, how quickly they press a button. In the post-error, the red and the blue line show the controls on the people who've used meth but have not got ADHD. They're all slowing down after they make an error. But if you look at the ADHD plus meth group, they're actually speeding up. So they're going in the other direction. So they're not effective at correcting their behavior. So we recently received a grant to look at this. And we chose to look at how working memory load, or you can think of it as adding an attention demand, how that affects your behavior in all of these groups. And what's important about extra attention demands and working memory load is when an addict sees something that reminds them of using, then it will automatically engage all these regions that are involved in attention control. So if you've got all this load going on already, then it leaves you at in a compromised state to deal with challenges, other cognitive challenges. So the idea is they're more susceptible to relapses. So we looked at just a regular working memory load. We weren't using drug cues in this paradigm. But if you look at the low working memory load condition, you can see the black line. The meth and ADHD are not slowing. They're responding at the same rate pre and post error, so they're not slowing down. In the high working memory load, this gets a lot worse. So you can see the line going down. They're actually getting faster, as they did in the previous slide, when you have high working memory load. And the meth without the ADHD, which is the red line, they're also showing some impairment in the high working memory load, where they failed to make these adjustments, which they were fine at doing in the low working memory load. So adding extra cognitive demand is hurting them, and it's meaning that they're not effective at monitoring their behavior and subsequently adjusting it. Interestingly, this is very preliminary data, so this is an ongoing study, but interestingly, if you look at our ADHD group who have never used substances in the past or been dependent on substances in the past, they are showing intact post-error slowing in both the low and the high working memory load condition. This is something that we don't usually find when we look at our kids and teenagers. It may be that this could be a clue as to risk for substance abuse, because these adults have never been addicts. They have ADHD, but they've never been addicts. So it may be that those successful people don't have this problem. So this could be a marker for risk, which makes it really exciting. And then I just quickly want to show you, it's the last slide, the area of the brain that's lighting up, the anterior cingulate. And again, this is very preliminary data, but we're seeing the black bar is controls. They're activating this region when they make mistakes, but you can see the ADHD are not activating. Actually, it's going the opposite direction. And the meth and ADHD are also having problems with this area. So error detection seems to be an important aspect.
I have been working in this ADHD lab for the last 4 years, and my dissertation has actually been coupling cognitive training with the parent education group that Dr. Dixon leads. Not to be confused with cognitive therapy or cognitive behavioral therapy or CBT, as you might have heard of it. Cognitive training is different. It is a set of mental exercises that target a certain major cognitive function, such as working memory. And working memory is your ability to remember a little bit of information at a time and manipulate it while you hold it in your mind. So one example would be, let's say you want to go to the grocery store and you just have a few things that you want to get, but you really want to get in and out. Maybe you have your kids with you. So you're thinking about the things that you have to buy, so you might be rehearsing them in your head, but you want to rearrange them so that they're in order with respect to where they are in the store. So you can just kind of do one loop, get in and out. You don't want to go up and down the same aisle twice. So in doing that, you're exercising your working memory. You're thinking about a list of information, and then you're manipulating it for your own uses. So for cognitive training, these exercises usually come in the form of games played on a computer at home that tax your working memory. And like exercising your body at the gym, cognitive training works best if completed multiple times a week for a multiple set of weeks. What cognitive training aims to do is to improve that cognitive function that is being targeted through these many training sessions. Okay. What research has been showing is that this training does have positive effects on the cognitive function that is targeted. And what's important to note is that these improvements are not only coming from practice, because these participants are improving on assessments that were not integrated into their training regimens. And improvements are also seen in other cognitive domains, such as executive functioning or parent ratings of attention, inattention, and hyperactive impulsivity symptoms for ADHD. These improvements have also been shown to last for at least a few months once the participants or patients actually stop training. So after they've completely finished, the improvements still remain. And the reason that we think this happens is because through these exercises, changes occur at the neurological level in regions that support the cognitive function that we trained. And like working out a muscle at the gym by lifting weights, after that muscle is strengthened, every other movement you perform that integrates that muscle is also improved. So if we're able to improve parts of the brain involved in working memory, which are impaired in ADHD, then we would expect to see improvements that generalize to the other cognitive and behavioral functions that incorporate those brain regions into their networks. And in a lot of ways, that is what we are seeing. But there's still a lot of questions that we have, and our lab continues to study this. Cognitive training is offered in various clinics for a pretty high price, but we're cautious to recommend pursuing it as a treatment because we feel like there's still a lot that we don't know about it. One thing that we have noted is that the treatment does not generalize to every setting, meaning its generalizability is not as wide as it really should be, given our understanding of the neurological effects that this treatment has. So for example, no study has been able to demonstrate improvements in teacher ratings of ADHD symptoms. They've only been at home by the parents. That leads us to believe that the improvements may remain at home, which is the context in which the training was completed. But that doesn't translate to the classroom, which is also obviously a very important context that we would want these improvements to translate to. So our lab just published a study examining this very issue, and I think we printed out a few copies that were out in the front. We monitored our participants while they completed a math test and found that the participants spent less time off task following the working memory training compared to the placebo condition. So now we do have some evidence out there for potential improvements that may transfer to the classroom. And we also just published a review article with our collaborators at Stanford that Dr. Schweitzer mentioned that touches on the research out there on this treatment, but outlines the questions we still have about cognitive training. We would like to find out if there is an optimum age for treatment based on the way we understand brain structures to develop at different rates with age, as Dr. Schweitzer had a really nice slide on, and how ADHD affects that. Perhaps there is a window of opportunity for training where the effects are most prominent. We would also like to find out more about how this training affects the reward systems that underlie impulsive behavior that you've heard about. There are some really interesting theories available explaining the neurological components of impulsive choices, and we imagine that if we could tap those through training, we might be able to also improve impulsivity in people with ADHD. And that idea has not really fully been addressed yet. So be on the lookout for new developments in the field regarding cognitive training. It certainly carries a lot of potential as a possible treatment, but a lot of work is still yet to be done.
So my talk today is about my life story in 10 minutes. And how it all relates to ADHD. So in my early years, I was one of those antsy kids that couldn't quite sit still. I'm still not the best at it, but then I definitely wasn't great. And in school, I did fair. Was okay, wasn't great. Probably, I'm sure teachers labeled me not working to my potential. Then I had to take the dreaded SAT. Not particularly wonderful in verbal or math, and so isn't that what it's all about? And I get into University of South Florida with academic warning. I then kept hearing I'm a late bloomer. So for a long story of how I actually got there, I got there late. I got sick right before school started, and I took 2 courses at University of Denver. They were upper level courses, 300 level, and I get A's in them. I'm like, wow, maybe I'm just interested in those topics. So I learned very early on, I compensated. I just, calendars, I took notes to stay focused so I would pay attention when the professor was talking, and I always made to-do lists. I am a big picture person. I knew I'm always more successful with a support system, so it was very interesting to see myself right on the screen. I'm not particularly great at the little details, and all throughout my years working on events or anything I was doing, I always rallied a troop. Come on, you'll be my co-chair or you'll help me. And that was a way that I could have them remember the little details, and I didn't have to, and I could always maintain the bigger picture and then monitor how things were going. So now fast forward 27 years ago, I marry my husband, Alan, and we have 2 boys. They're currently now 25 and 23. And they both have ADHD, and they both were presented differently. When my older one was diagnosed and different things happened, we ended up taking him to a psychiatrist in town, and she's interviewing Alan and I, and she says to me, "Oh, do you have trouble sleeping?" And I went, "Uh-huh." And she said, "Well, do you," and yelling, "Yeah, oh yeah, I grew up in a yelling family at times, and I yell." "Well, if you would like to, deal with that, please come see me." Okay, so I actually, it was Halloween time, I think I yelled one too many times. I said, "This is awful. Okay, I'm gonna go see the lady." So I go see her, and she says, "Well, you're hypomanic." "Oh, okay, that means you function up here." Fine. She puts me on medication, away we go, and I think I was on it 5 or 6 years. Now, my older son, who then comes and works at the mine for 1 year with Rondi Hagerman and the doctor, and he was part of the FACS test program and needed research control groups. Well, my husband and I were his volunteers because he was needing them. And they do the psychiatric test. Interesting, I say, "Yes, I'm hypomanic," and they're doing the psychiatric test, and they're like, "Well, when you cycle." I said, "No, I don't cycle." So I said, "What are you talking about?" I said, "Cycle." "No, well, when you get depressed." No, no, I'm hypomanic. I stay up here. "Really?" And then they're watching me put on hand lotion, and I'm doing 6 things at once, and they're like, "Okay, she's definitely ADHD. I'm not sure about that." Fast forward now. I am not hypomanic, and I'm on medication. Really? This is not working. So I get assessed, and because I was currently the chair at the time, knowing about our great adult child ADHD clinic here. And in April of 2010, I am put on Adderall, or amphetamine salts XR, and I get to see Dr. Packrat. So here's what I discovered about how my ADHD became so clear. That interrupting. Excuse me. I'm listening really intently, and I am, but meanwhile, I'm so afraid I'm going to forget to tell you something, so I need to interrupt. Or in the board, we always had our board meetings, we would take notes because the researchers were coming in, and I need to be able to talk, and I want to focus, and I'm taking my notes, and then they would be talking, and I'm taking these notes, and if you looked at my notes, they never really finished the sentence because they went on to something else, and I would have these. And then it's like, yeah, I did that in school. Newspapers. Okay, I'm great on page 1. This is kind of interesting. I would kind of flip back and forth. This is kind of holding my interest, not that much. And then you flip to the back page, wherever it was. The worst was when you, God forbid, had to turn to page like A14, and then it was A14 and 15. That meant the whole page, both sides, are all about whatever topic. And then I would go back and forth. I did find lectures painful, but particularly I find boring speeches a nightmare. Sitting through them, I find it was torturous. And I also learned that I would jump from one thing to the next. So I could put something here, and then I would go over there, and then I would go there. But I was getting things done. I always perceived myself as accomplishing, but I wasn't always focused. So now the Adderall. Now I take it, what happens? I lose weight. Well, what's wrong with this? God, this is great. I can eat whatever I want. And I think this is the greatest thing. I'm excited. Okay. If there was a sense of calm. If I found that I forgot something in a conversation, I now know it will come back. It's not like, don't. So I even will say, I forgot it, but it'll come to me. And I forced myself to read a newspaper the correct way. And I had to initially self-monitor myself to say, don't be starting with this, bouncing around. You can do it. And once I kind of got through that, it worked. New issues. Starting a new business. I don't have money for a support system, somebody to go to help me. So I'm finding that was really difficult. It means that if you come in our office, there's a lot of papers all over, filing, or the worst aspect for me personally, and it's never really been easy, is writing. I don't mind speaking, but writing has always been difficult, and I will avoid that. And I do listen. Oh, God, you got an email. Oh, who was that from? Oh, God, I want to read about that. So I'm finding all of the things that your kids are distracted, me too. And of course, I'm now focusing to make a list and trying to stay on task and upping my medication to like 40 milligrams, and it is helping. So where does this leave me? This leaves me in an area of my own personal mission. I never minded telling people I had ADHD. I never felt there was the stigma, and I feel badly when I hear other people having that problem, being afraid to say something, or having some well-meaning person in a room attack them because they put their child or themselves on a medication. You're doing that. It's so difficult, and it's so not necessary, and it's so disrespectful. And I have pulled someone aside and said, you know what? It's a good thing, you're doing the right thing, don't worry about it. Or I have confronted people to say, really, this is something you're not even dealing with facts. It is something that the problems that are going on, it didn't mean that my mind isn't working. It just was working overtime and not being successful. And I was not being productive. So what is wrong with that picture? The bottom line is I'm taking the medication. I feel terrific. I'm being far more productive. And I think my younger son said it best when he said, you know what, it reminds me of the difference between being a stick shift with a car, driving a stick shift versus automatic.
My role here tonight is not really from my professional background, except for the fact of communications and advocacy. Why I'm here tonight is because I'm a parent. I'm a parent with 2 ADHD children and a spouse. And if you don't think that doesn't wreak havoc in my household, come on over, visit me any single time. It's Disneyland half of the time at my household. I have a 15-year-old boy and a 18-year-old boy. They are process to get them diagnosed was not a straight and linear path, as I'm sure those of you who are parents who have kids that have been diagnosed, you kind of go at it at any which way. You start finding out that they aren't cleaning their rooms. I mean, half of the things that are on here that are just really my household and my life. And I wanted to share that with you to say that we're all in this together. We have similar experiences. Nancy, thank you for saying don't be ashamed, because there were a lot of years when I was a little bit concerned about saying my kid might have this. And then I realized as I've gotten through the years that I am the expert in this, because these are the clinical experts, but I'm the expert in my own children, and I've become the expert in this issue, and I need all of you to become the expert in this issue as well. My kids were first diagnosed with the usual kind of in school, can't stay focused, can't figure out what homework he has, can't find it in the binder, all the typical things. The room is a disaster area. You tell him 3 things, and he can only remember 1. From there, we start the diagnosis process with a clinician, his primary care, as everybody always does, and you go through this checklist, and you're kind of figuring out, does he have more than 10 of these symptoms or 6 of these? Is it hearing? Is it eyesight? You go through all of these. Meanwhile, I've got an older boy who is also not doing all that well in school and is starting with anger and is starting with his own self-esteem issues and pressure, but he's presenting very differently. He is presenting very quiet, reserved, not energetic, has no passion for anything, has a couple of friends, but not necessarily outgoing, energetic, involved in school, involved in sports or anything else. So we think, as our early learning process goes, we think he's just lazy and bored. We see the very inattentive, unfocused in one child. The other one is just bored. So we go through the diagnosis process, we understand, we start reading, and I would absolutely recommend you read everything you can get your hands on, because every kid, every person, every adult represents differently. And I wasn't smart enough at the time. I hadn't read enough. I hadn't been around my community and all my colleagues to know that. So I started to read, we started to go through the process, and I'm in bed one night where I do all my reading, and I'm reading all my books, and I'm going through the checklist, and I'm explaining this to my husband, and I thought, wow. About 8 of the 12 of these are him, and I didn't want to accuse him or say, look, you have something, did you know? And so I start reading him the checklist, and he goes, yeah. And he sat with that for about a day, and then he said, you know what, that would have explained a lot of my early employment history. My writing notes that I couldn't figure out where I left them, assignments that my bosses had given me that I never concluded. The company that we started 10 years ago that's hanging on by a cliff right now, not only because of the economy, but the way he's managed. So we've had school issues, relationship issues, employment, financial issues. Name one. You probably have them in your household. I hope you don't, but you've probably had them in your household as well, because it usually is that this is ADHD, depending on whether you have 1 or 5 or all of you, is a family affair. And how you all deal with it, and how you gain your support systems, and you need support systems, and you need strategies, becomes a family affair. Here's my also other line, which is, because Hillary Clinton coined it so well in a book, it takes a village to raise a child. Specifically in my world, in ADHD world, for my children, it's taken a village. It takes school. It takes the Mind Institute. It takes the physicians. It takes friends. It takes just support groups. And I was never big on support groups because I was always very personally self-focused, dedicated. I can do it. I can handle it. And this is the one issue where I said, it is a family issue. It has multiple symptoms in finance, in our marriage, in a raising of our kids, in their self-esteem, in their self-success. So I need support. And I found it to be, it takes a village. So having what I learned, let me tell you quickly what I think I've learned. And hopefully some of this will have bearing, and hopefully you won't have to go through the hard learning process in cases that I have, which is ADHD is a disorder. A lot of people, a lot of teachers I've met want to just slough it off and say you have an unruly or an inattentive kid. Quit with the sugar, quit with this, he'll grow out of it. No, it's not true. Don't let them tell you that. It is a mental disorder, and it needs, your child needs support, they need help, it needs management at every level. It needs management in our case with medications. We've been on Vyvanse, we've been on Concerta, and again, you test it, you try it to figure out each one is on their different medication and different dosages at different times. So each one becomes very different. Kids and families need also the support systems and tools. They need to learn how to help manage themselves. We tried binders and organizers and alerts and all these other, different folders for different things. You just have to test it and try it and find what works for yours. It takes a village, so find your community, don't be embarrassed about it, reach out. Everybody I talk to now that I say I have ADHD kids, you'd be surprised at how many come back and go, I do too, or I know somebody who does. Be patient with yourself. This is one thing I wasn't good with myself. I could just tackle it. For those of you who have all of this going on in your house, or a kid that is getting angry or depressed, or some of the other symptoms that go with this, it's very easy to get angry or depressed or something back. Be very patient with yourself and be very patient with them. Find your community. Be patient and love them more and more and more. I figured I loved my kids, but when I realized they were kids with very specific issues, that I was the mother that I needed to advocate and help them, half of that was part of the prescription, half of it was just love them more. Love them for who they are. They're not going to take a direct path. They may take a winding path. Some of them are going to be successful. Some of them are not going to be so successful, but they are their own people, and you need to love them more and love yourself more. Last thing I wanted to say, because I think I'm almost out of time, is there are 15 million Americans that have ADHD that have somehow been diagnosed. So we are not a small community. We're not just individual families. There are a lot of families and that are struggling and that we can learn from each other. The one thing I would recommend, or the couple of things I would recommend as a parent having done this, which is, one, educate yourself. You are the expert on your own kid. You are the expert in your family. Don't let anybody else tell you you're not. Half of what you heard here tonight is education on the actual what ADHD is and how it presents itself, but you're the expert. Become an expert, advocate for your children in school, in the medical community, which I represent, and in every community that they're involved in, sports. Advocate for your child. I didn't do it soon enough. Advocacy is what I do on a day-to-day basis, and I didn't stand up because I was a little afraid early on to make my point known or make my opinion heard because I was the expert of my child. Don't ever do that. You are the expert. And the other expert, or the other voice you need to have, we need to have as 15 million Americans to do this, is with the California legislature and other funding mechanisms, the NIH, anybody else who can help continue to fund what these phenomenal folks do every day to help us. Funding, state budget, federal budget is going to be cut. With it become discretionary fundings. You already heard about Big Bird and everything else, but the NIH is up for that as well. We need to help these folks get the funding to continue to do what they do. So you need to be an advocate for your child and an advocate with our legislators to say, we need to fund this. It is a real disorder. It deserves to be studied. It deserves for it to have support. And one thing I'll say about, because I talk to a lot of folks that aren't advocacy folks, and it kind of makes them very leery, is remember, because you're going to have an opportunity to vote very shortly in about a week for who you want to represent you. I get paid to advocate. You don't. So when you call a legislator or talk to somebody and advocate on a particular position like ADHD, we need some more funding, we need some more support, you're doing that because you put them in office. You voted them in. They are responsible to you. You really have the power here. We can put out grants, we can do a lot of things, and we do every single day, but you really have the voice and the power with your school and your legislature and funders. So don't be afraid to use that voice on behalf of your child for what these folks do for us every single day. Thank you.
I was just wondering, with regard to medication, what amount of side effects is okay to be okay with before you say, I think we better try something else? Is the stomach aches or the insomnia, or like how many of them combined before you say enough?
I think, I think it's different for different people, and I think mentioning to your physician when you have a side effect, whether or not it's gotten to a point where you think it needs to be addressed by changing a medication so that they're aware and they're monitoring with you, is really the key to this. And, monitoring functioning, usually it's about how well is somebody functioning, where are the benefits, how much is the risk, and are there other ways? Because sometimes, the answer might be take it at a different time, take it with food, so depending on what the side effect is, there might be workaround to it. And so I often will tell parents, use your physicians, because you're the experts on your kid and they know mental health and medications, and work together so that you can find the best mental health and medication for your kid. And so I really think it's kind of working with the physician to find that right answer, because that's different for different people.
Can I add one thing?
Yeah, sure.
We also see a lot of parents that they go from medication to medication. Within a month, they've been through 6 or 7 medications. That is, you have to talk to your physician, find out what the mild and temporary side effects are first. Because I don't want you to stop giving your child a potentially very helpful medication, because of 2 days of mild nausea that lasts about 15 minutes. The child, especially if you have an anxious child, they will overreact to that side effect. But if you have the big picture, if you can see the light at the end of the tunnel, perhaps you can support the process and the outcome may be worth.
I was wondering if there are any other non-stimulant medications in the pipeline or any sort of off-label uses of other medications for ADHD.
There are several.
Yeah.
One of the, we'd like to,
There are several, I guess, off-label, so it's to say medications and that can be used in ADHD, usually when you've kind of exhausted some of the more, regular options. Again, weighing the risks and benefits for each individual patient, so.
but also in terms of non-stimulant, we have atomoxetine or Strattera.
Right, so that's the non-stimulant that
And-
we talked about. The
right.
newer ones was, kind of
Tuna.
the guanfacine that's recently come out in the longer acting versions, and also the clonidine that's recently come out in a longer acting form. So there's just the idea is to kind of try and get more benefit out of the ones that we have by extending their time periods and kind of looking at others that we can use.
And there are different studies looking at the effectiveness of the different compounds and so forth as well. But most of it seems like in the past few years, it's really been different formulations of many of the same medications. I find in other areas of brain disorders that there seems to be a lot of emphasis in developing new compounds, and I haven't seen as much of that in ADHD, and I think that's something that should be addressed, because I think we could be doing better. We're actually, the medications we have are highly effective, but I still think that there's room for improvement.
Right, and I think some of the compounds they've looked at, in terms of research and some of, targeting different neurotransmitters, so looking at nicotine receptors or other receptors in the brain, really some of the early studies have not been very promising. So there are definitely studies going on, but we haven't really found a compound that's been promising in terms of then translating it into using it more commonly, so.
I think one of the other issues with ADHD is that we know for many people, it's almost a lifelong disorder. And other neurodevelopmental disorders ebb and flow sometimes, but with ADHD, many of the symptoms are in adulthood as well as the younger years. So people are taking medications for a much longer period of time. So I think we have to take that into account. The other area is looking at how non-pharmacological treatments can be integrated with pharmacological treatments and to see how that makes a difference. And there really hasn't been that much work. So for instance, even the cognitive training, would that make a difference if you had as well a pharmacological agent on board? So there's a lot of work still to be done, even though we've known about this disorder for many years and it's been treated since, I think, 1937, some of these compounds. We still have a lot more work to do.
How common is it for children, or how many of you have seen patients that are children that really respond better to a lower dose of a medication for ADHD below like the target dose that the average kid of a size or weight would respond to?
It's certainly, we always start at the lowest dose and then kind of go up rather than starting at a high dose and going down. So that's the usual strategy. I'm not sure if that answers your question.
I'm actually referring to not even a low dose, but a dose that would seem to be significant, not significant at all. For instance, if you have a child that's the target dose would be 25 milligrams of atomoxetine, but they would really do better on 10 milligrams. Do you see that a lot? Because I seem to have a child that for every drug, he needs to be, taking these micro doses.
Right. So certainly,
common?
because different people metabolize medications differently, and so based on kind of what their, hepatic enzymes or how they're metabolizing medications, some people just need higher doses of things, and some people just need lower doses of things. So that's certainly possible based on, kind of the makeup of that particular kid. If they metabolize medications in a way where lower doses can go a longer way, then that's certainly possible.
Thank you.
Yeah.
Also, we are finding that if your child has a comorbid condition, child has ADHD as part of autism, child has ADHD with comorbid generalized anxiety disorder, comorbid depression, they tend to have very sensitive brains, very sensitive receptors, and they will do actually fantastic with extremely low doses. Sometimes they will come to me from pediatrician to us, and then we will just reduce the dosage. That's all we'll do. We'll go from 3-4 medications to just single medication at a very low dose, and the results will be much more helpful than the previous dosage, which may have been higher. So that's another thing, that the higher the comorbidity, almost the lower the dose for certain cases.
I was wondering if you could talk a little bit more about the pharmacogenomics that you were talking about earlier. There's a couple of things I was wondering. I wanted to know, first of all, whether or not it's targeting specific neurotransmitters, or how it is that you are tailoring this for a specific disability. And also, I was also wondering if there are also studies being done on other kinds of genetic predispositions, so that it's tailored for also people with bipolar disorder, or people with schizophrenia, or people with autism, etc.
That's a great question. This is really very exciting because it helps us, all the side effects that the parents complain, and sometimes going through multiple medications to find the right medication. It will help us with that. And we are in a way lucky because, we did complete the Human Genome Project, as you know, was very successful. We have much better understanding. Mine Institute is extremely advanced in terms of Fragile X and other syndromes with understanding their genetic makeup. But this particular pharmacogenomics, they actually look at the enzymes that are linked to certain proteins and certain gene structure. So if the protein is the product of a certain gene or a gene system, they are looking at those proteins and as markers and the enzymes. So you can do that for antidepressants, you can do that for anti-ADHD medications, and they are talking about using this strategy for schizophrenia treatment as well. We are so excited about this because I think it will, number one, it will help reduce the stigma that our advocates discussed earlier. But that's the approach strategy. It's quite expensive at this point, but usually, like with new medications, the more available they are, the more affordable they will be eventually. So again, I'm hoping within the next couple of years we'll be able to use this as part of our initial assessment here at the Mine Institute, of course, with LENS support, but we are hoping it will happen.
Yes, how do you diagnose an adult, make an accurate diagnosis with an adult with ADHD if that person doesn't really have any known history of what their childhood was like? They were just being a kid, and yet it says these people have to be diagnosed in their early ages, before 8 or something. And how do you know that it's ADHD versus anxiety and mood disorder or any of the other myriad of things it could be?
That's a great question. And there's certainly a lot of variability in how people conduct an adult evaluation. What we try to do is gather as much information as possible, and oftentimes it feels like detective work. So for sure, I need collaboration in terms of, for current functioning, we ask the individual to rate themselves. We conduct an interview with them. We also talk to somebody else who knows them well currently. And then depending on the age of the person, I do try to get as much information from childhood as possible. So I've had people who were in their 50s and were able to locate report cards. And so that's one of the first questions I have for people, whether they have some collateral information. And so we do try to find that. We try to find if they don't have a parent available, maybe they had an older sibling or a neighbor or somebody who knew them fairly well. We do ask for themselves to fill out retrospective rating skills, but we know the validity of that is somewhat questionable. So then we'll ask for anecdotes. And we also, at the same time, we have to look at things like anxiety and depression and the family environment and the culture and so forth. And it varies from person to person in terms of how much information we have, but there does need to be some indication that at some point in childhood they were struggling. What we use for diagnosis, we have this guidebook called the DSM, and it's changing in a few months. The new DSM-5 is coming out, and it now says you have to show evidence of ADHD by the age of 12. Previously, it's been by the age of 7. So this is also helping us because there are certain circumstances when you're older that become more challenging, and that's when you start seeing more evidence. But to be honest, a lot of times it is detective work.
Can I just address something related to it also? When I was looking and telling people that I did have ADHD, and they would say like, well, I do that. I go from room to room, or I do all these things. You're not saying that. You seem so, I can't believe you have it. You seem so quote unquote normal. But what becomes the real issue is it does have an effect of being as productive. And when it starts when it's like an aha moment, had I not realized I was on the wrong medication, that I was even misdiagnosed, I'm not sure I would have ever really been diagnosed, because I was really moving along fine, compensating as I go with my half-finished sentences. But then when you do see the difference, then it becomes, but wait a minute, if it impacts your life, if you're not being able to be as productive and effective as possible, that's when you have to say, maybe I need to look at this.
You talked about always advocating for your child. What do you do when an adopted child is in his late 30s and he's a disc jockey in Las Vegas and you don't agree with it?
I think, actually, I think he's probably at the point that he is going to advocate back to what he wants to do with his life. And as a parent, we always want the best for our children, but literally, I don't think there's much you can absolutely do at that particular point, except for tell him you love him, tell him you support him, tell him to find a real career at some particular point, as my mother did.
Hi, I wanted to ask about level of severity in adult ADHD and what you think is, I'm ADHD and I know my mom probably had it, but like my cousin has it and he's like worked at Microsoft for 25 years. What's the difference? I'd never had any kind of education, 25 jobs, probably more than that. And then also, and that kind of is for everybody, then also for Nancy and Tracy kind of mostly, but also for everybody, what do you suggest for books and websites and stuff? I've read a lot, but just wondered if you had any suggestions on that.
Would you like me to handle the severity? Okay. So there's a wide range in terms of severity, and I've met physicians who have ADHD, and they're bright, well-educated, but they've stumbled more than one would expect. And I've met other people who are really stuck, like you, who've said you've had 25 jobs. I've met people who were young adults in their 30s living at home with their parents and had an IQ of 130. And they can't get out, and their parents want to retire and move on, but they feel like they can't do that. So the level of severity is huge, and it's not necessarily reflected in things like IQ, but it's finding the right support, it's finding your passion, what you're willing to work toward. We've talked about it's also, if you can, it's finding administrative help, because a lot of people, I meet a lot of adults who are great salespeople, then they get promoted to a desk job and they're miserable. And so it's finding your niche as well. Also, remember brain development. We're learning that in ADHD, it might be not till your 30s that your brain stops developing in some of these compensatory areas. So there's hope there for a while as well. So there's a extremely wide range. If you have learning disabilities, that complicates things. If you have comorbid depression, anxiety, which is not unusual at all, that's going to complicate things, and obviously substance abuse. And the more complications and the fewer supports that you have, that's just making the road more challenging. In terms of website, I'll let them handle it, except to say on our website at the Mind Institute, we do have links to other websites. And the National Institutes of Mental Health is one of the best links that you can look at, the American Academy of Pediatrics, also the American Academy of Child and Adolescent Psychiatry. I will warn you that some websites do not have valid information and do not have evidence-based information, so you do need to be cautious about what you read. There is a lot of strong feelings about this disorder and its treatments, and you need to verify some of the things that are out there on the internet.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.